We're very excited to share this space with you today, and thank you to the Latinx Mental Health Institute for the invitation. So our study is titled Experiences of Bilingual Spanish-Speaking Mental Health Providers Seeking and Receiving Bilingual Supervision. My name is Dr. Camila Pulgar, and I work for the Wake Forest University School of Medicine here in Winston-Salem, North Carolina. Next slide, please. So this is how we're hoping to spend the time with you today. We will tell you about who we are and why this work is important to us. We will tell you about the background of our study, literature reviews, and things that we've done. And then we will jump to the fun part, which is the study itself. It was a qualitative study. We'll walk you through the protocol, the analysis, the findings, and then we're hoping to have a lively discussion towards the end about our results and future directions. Next slide, please. So we received some internal funding, myself as the PI in this study, and the support from the National Center of Advancing Translational Sciences via the CTSI here at Wake Forest School of Medicine. So we wanted to acknowledge their support, and we used the funding for incentives for our participants. So who we are. In the next section, we will talk about our background. I will go first. My name is Dr. Camila Pulgar. My pronouns are she, her, ella. And I'm an immigrant from Chile. I'm a wife and I'm a dog mom to Luna. I received my master's from NCINT, my master's in clinical counseling, and my PhD from the University of North Carolina at Greensboro. I wear many hats, but mostly I'm a researcher since my position is a research faculty tenure track position. I'm a consultant. I'm a licensed professional counselor here in North Carolina. And in my research position right now, my research agenda is around bilingual supervision, but as well as Latinx mental health with a specific focus on suicide and suicide prevention. I also own a business called Salud Mental Health, which is an organization that we're dedicated to bring awareness, mental health awareness, connection, and resources to our local Latinx community. And in the past few years, I have served as the board member for the American Foundation of Suicide Prevention, as well as the National Latino Behavioral Health Association. And in my clinical work, I'm also trained in both brain spotting and EMDR. So now I'll pass the ball to the rest of my team. They have done excellent work in this study. So Dan, go ahead and introduce yourself.
Thank you, Camila. Like Camila shared, my name is Daniel Dosal Terminel. I use él, him, his pronouns. I am considered what's 1.5 generation from Mexico. From Mexico City. I got my master's in Texas at St. Edward's University, and I'm currently a third-year doctoral student in the Counselor Education and Practice program here at Georgia State. I also wear many hats. I'm a researcher, educator, and I'm a supervisor in training. I have done a lot of work, systemic work in schools, communities, and churches. So I work with school counselors as well as school-based clinical mental health counselors. I'm really interested in working with kids and their families, specifically around immigration trauma. And therefore, most of my clinical work is trauma-based. Therefore, I do a lot of narrative exposure therapy, and I'm working towards play therapy certification. My passion is connecting other Latinx individuals and clinicians together so we can provide services to those who need it, whether they want to go to a hospital, a school, or a church-based type counseling. I feel like we need to connect all together so we can better serve our community. So that's me, and I'll pass it over to Kimberly.
Hello, everyone. My name is Kimberly Mendez Gomez. My pronouns are she, her, ella. I'm a student in the Clinical Mental Counseling Program at Georgia State University. I'm currently entering at Atlanta Relationship Institute, where I'm able to work with the Latinx community and offer therapy in English and Spanish for all ages, adults, adolescents, and children. I'm very passionate about helping people and drawing the attention to the great demand for bilingual counselors in Southern Georgia. And my motivation is to try to break the stigma of mental health within the Latin population here in Southern Georgia. I'm also interested in doing more research about bilingual supervision. So that's about me. So why is Spanish-speaking bilingual counseling important? Next slide, please. So in Latinx in Georgia and North Carolina, the immigration population continues to increase in the United States. The highest growing Latinx population is Georgia and North Carolina. Many people would say Texas or California, but the data tells us different. In North Carolina, between 2010 and 2018, the US Census Bureau estimates that North Carolina Hispanic population grew by 197,000 new residents, an increase of 24.6%. According to Latin American Association, Latinx individuals account for about 9% of Georgia's population and 11% in North Carolina, making Georgia and North Carolina among the top 10 states with the largest Latinx population. Next slide, please. So counseling in the US, counseling programs are primarily in English. Little research has been done on the training and experience of Spanish bilingual counselors. Less literature does exist on accessing supervision. So that's why this research study is so important to understand what training is needed when working with bilingual professionals. This information will allow bilingual counselors to become more competent and be better prepared to help Spanish-speaking clients. Next slide, please. So the bilingual counseling studies, the meta-analysis in 2020 found 15 studies. The topics were about client perspectives, counselor perspectives, training and supervision, exclusively training or supervision, or a mix of everything. The design that was provided was mixed, quantitative, and qualitative. Next slide, please. So the topics that we were able to find regarding to bilingual counseling were these articles. And what we found is that this is challenging since most trainees obtain their master's level training in the dominant language, which is English. Trepal, Ivers, and Lopez is one of the few studies that looked at the lived experiences of both supervisors and supervisees who engage in bilingual counseling. Their participants were dyads of Spanish and English speakers. Participants reported challenges of translating their thoughts from their dominant language to their second language, using technical vocabularies, understanding the language and cultural variations between Spanish-speaking clients, and limited practice working with English-speaking clients as well. So these results were important to consider in training and research and counseling, considering that the rapid growth of bilingual population in the United States. So more studies were also coming along as well. Like these are needed more to understand what training is needed when working with bilingual professionals. Using the framework and the interview protocols from Lopez and Torres Fernandez, which is what we use, this study will add to the literature on highlighting the needs and lived experiences of bilingual mental health counselors living and practicing in the states of Georgia and North Carolina regarding to accessing the experiences in clinical supervision. Also, understanding the experiences of bilingual counseling students is imperative for the training and bilingual counselors and overall service delivery. Many students who provide counseling services in Spanish are trained in English language counselor education program. The challenges that bilingual counselor service experience are difficulty with translation, change in self-efficiency, differences in language, and the lack of resources. But the main problem is the lack of formal training in bilingual counseling supervision. So we did find an article that talked about training and how it can better help us be prepared. So in the training section, we found an article that outlines the steps taken by one clinical mental health counselor program to design and implement a Latinx counseling concentration within the existing curriculum. Outcomes achieved and lessons learned in the first 3 years are offered as recommendations to other institutions, recognizing the need for a similar concentration within their counselor preparation programs. So we're hoping that this article is able to give us a little bit more knowledge how we can implement that information into our own curriculum later on in the future, hopefully. Next slide, please. So our current study. So this study aims to explore lived experiences of Spanish-speaking bilingual mental counselors practicing in large Latinx destination states like Georgia and North Carolina, specifically interviewing 10 bilingual counselors about their experiences and receiving supervision. Replicating the Lopez and Torres Fernandez interview, we were able to find out more information about clinical supervision and talk about experiences regarding to accessing, receiving, and overall experience. Next slide, please. So we normally met every week or every 2 weeks to talk more about our research regarding to subjectivities, bias, and providing bracketing strategies. So what we did is we live in receptive states. Me and Dan live in Georgia. Camila lives in North Carolina. We all identify as Latinx. We identify as bilingual counselors as well. We're all trained in English-only programs. We experience providing Spanish-speaking services, and we are immigrants and first generation as well. Next slide, please. So for our study, we ended up asking 10 participants, and 5 of them were from Georgia and 5 of them were from North Carolina. The way we were able to recruit them was by using the snowballing sampling. We used flyers, social media posts, word of mouth, professional networking settings, and personalized recruitment emails. We ended up compensating making a $50 gift card to participants who were able to do the interview. And we are IRB approved. Participants had to consent to participate and be recorded before the interview started. And our criteria was to be a licensed mental health provider in North Carolina and Georgia with up to 8 years of clinical experience. Next slide, please. So our protocol was to complete a brief demographic survey prior to the interview. We ended up giving code names, so we never used our participants' names at all. The participants participated in a 60-minute virtual interview. Only audio was recorded, and we kept the data analysis. We never kept their name, we never showed their face, and everything. And if they did say their name, we did end up blacking it out, so that would never be shown. Options to do interview were in English and Spanish, but all of them did end up choosing English. And they, like I said, they did receive compensation after the withdrawal of the project. Next slide, please. Okay, so the interview protocol, like I said, we did do the replication of Lopez and Torres Fernandez semi-structured interview for supervisees. We had 10 potential questions. The categories were overall experience, training, supervision, and recommendation. Next slide, please. So the participants that we end up having, or like I said, 5 from Georgia and 5 from North Carolina. They were all women, 1 Indigenous, 8 Latinx, 1 Latinx, and white. The license that they ended up having, like you can see on the right side, was from LMCHC, LMFT, LPC, and LAPC, so from Georgia and North Carolina. And the participants either were in private practice or community settings. Next slide, please.
Awesome. Thank you, Kimberly. So the methodology that we ended up using for our qualitative process is IPA, or interpretive phenomenological analysis. It is like an experiential approach to qualitative research, and its philosophical underpinnings, as you can see on this picture I provided, are phenomenology, hermeneutics, and ideography. Phenomenology is to describe someone's lived experience and trying to understand their full experience. Hermeneutics is the theory of interpretation, so we as researchers will be interpreting their words. And ideography, which is the focus on the individual. I'll talk a little more about that, how we go from the focus of the individual and their experience, and then try to make a larger meaning with the sample throughout this kind of discussion. So as you can see on the picture on the right, this is kind of like a timeline on steps of our qualitative analysis. So once participants were recruited, did the survey, and did their interview, we would, like Kimberly shared, made sure that we cleaned, transcribed the interview, and then shared it amongst ourselves so that we can initiate the coding process. Our coding process was very much like this picture shows, where we read and reread with audio, without audio, began the initial, what's normally called first order analysis of initial coding. Then we moved on to emergent themes, and then looked for clusters of themes. I'll go a little more into detail about the individual coding process in the next slide. But essentially each individual transcript went through this process individually. So they ended up with their own individual coded transcript, individual code book, and eventually in an individual theme book. So 10 of each for each participant. And so our coding process, like I mentioned, required a couple steps that IPA requires. So during the second rereading, the coder would leave what's called exploratory notes. They can range from descriptive, what is being said, linguistic, what are the actual words that the participant uses, and conceptual notes, which require us to be a little more interpretive, but looking into or digging into what the participant's actually saying. Once that is done, we go back and read our notes and the transcript and try to formulate experiential statements, which is a concise statement or summary of what is actually emerging. And eventually, once we have all the experiential statements for the transcript, we would look for groupings, connections, clusters of these experiential statements, grouping the similar ones into superordinate themes. And this is, I'll talk a little more about this later, but essentially we combined and created our own table of personal experiential themes, and naming each group and the matter that we thought really brought together the individual words that we were using to describe our individual's experience. Like I mentioned in the prior slide, by the end of this process, each individual transcript had their own coder notes, their own exploratory statements, their own quotes, their own preliminary clusters, and their own individual themes. And therefore, once we had all this, we can then begin cross-analysis. Like I mentioned before, we had a Excel sheet where we put all these things together. So when we came together to show each other a participant's code book, theme book, and coded transcripts, the other two researchers could scrutinize individual codes and or theme names and things of that nature. And so we would have teams meetings where we would show these to each other, kind of explain our process, explain why we chose certain things, until we reviewed all 10 code books and theme books. We then combined and compiled these theme books and kind of restarted the process again of comparing themes, clustering them depending on the connections that they had, any similarities, and brought them together to create superordinate and subordinate themes. So what did we find? I think it's important to describe our participants a little more. So on the left here, you can see the state they're from, the identity that we described, their ages, their license, their gender. And on the middle to the right half of the table, what you would see is kind of the questions that were embedded in the interview to ask them about their supervision experiences. They all identified as native Spanish speakers. They all did not receive any formal training in speaking Spanish in counseling settings. For those of you that don't know, when it comes to counselor training programs, usually you have to do a practicum or internship where you end up having a supervisor in the school that supervises your learning in the school training program. And then you also have a supervisor in your on-site setting that you're delivering services. And so what we found was that none of our participants had a Spanish-speaking graduate program supervisor. And only some, as you can see here, and I'll have a table that shows it by state, had on-site Spanish-speaking supervisors. What we also found interesting is that although this was not part of the interview, several brought up after not having a Spanish-speaking supervisor, looking for one, and or after having one, sticking and continuing to have a Spanish-speaking supervisor. So in this table is kind of what was shared on the last table. The brown part is pretty much the same thing. As you can see here, in Georgia and North Carolina, 0 participants had training, while in Georgia, 4 of our 5 participants did have an on-site Spanish-speaking supervisor, while in North Carolina, only 1 did. What was interesting that in Georgia, 1 participant decided to not pursue post-training Spanish-speaking supervision, while in North Carolina, and 1 extra participant did. This will be discussed later in our findings, but our interview didn't really ask questions about community settings, community agencies, or anything like that. But as we began asking about supervision experiences, many of them began to share about how they began working for the population, how they were able to access the population to create services, and many of them shared having some sort of community agency setting as their internship, practicum. And what was interesting is that in Georgia, they all described what it was like to work in those settings. 3 of them talked about how much the agency did not have the infrastructure to support them or their clients, and I'll talk a little more about this later. While on the other hand, 2 in Georgia did find that the agency did provide support for them and their clients. North Carolina, like I said, this was not necessarily part of the interview, so it was an interesting finding that in North Carolina, it wasn't really brought up, and the only person that did bring it up was 1 person that had an amazing experience in their community setting. And so that's something to keep in mind as we move kind of forward. So what did we find? This is a list of our superordinate themes. I will definitely explain these a little more in the following slides, but we decided to group them into these 4 categories: overall experience, training, supervision, and community agency. I'll go into more detail into what's listed under these in the next following slides. But I just want to let y'all look at it for like a minute. Perfect. So what were the subordinate themes associated with these larger themes? So when it came to their overall Spanish-speaking counseling experience, one of the main things that got brought up was the personal in providing Spanish-speaking counseling. All of them shared having a personal identity with the population, and the work was more than just a job. It was deeply personal for them. All the participants shared some sort of immigration story, being a big contributor into why they do the things that they do. And they all mentioned having the skill, even if it was low language proficiency to high language Spanish proficiency. They all recognized that they had the skill and there was a need, and why not use it? And eventually it really came ahead into wanting to serve the community as they noticed more barriers and things of that nature when it came to Spanish speakers accessing counseling. Another thing that got brought up by all our participants was the nuances of Spanish speaking counseling. because our population sample, was diverse in their language proficiency, it was hard to really cluster some of the things that they said. But what we did find interesting, they all mentioned having cultural humility, and in the sense of taking in a person's dialect when they're thinking about cultural background. And so it was very interesting hearing from people that would say, well, I grew up in Mexico, learned Mexico Spanish. A lot of my clients are from Chile and they speak a little different. And so I had to learn kind of those things and really be humble about my Spanish use and my the dialects that they're using, the little nuances of kind of what's happening in the room. Several of them disclosed having to ask them about their clients about the dialects and things of that nature. And so that kind of brings us into the difficulties of Spanish counseling that they all shared. Most of them shared not feeling supported in one way or another, whether it be by their supervisor, the agency, others around. They also really spoke about there not being Spanish resources, whether it be as a clinician Spanish resources and or referral Spanish resources. So for example, many of our participants talked about working with domestic violence, but not being able to refer people that they think should go to a safe house or things like that because they didn't have a Spanish speaker on site that could support that individual. So it made providing services really difficult. As well, they all spoke about, while I do speak Spanish, I didn't receive training in clinical Spanish vocabulary, and therefore a lot of them had to seek growth in their Spanish clinical vocabulary and how to use it. What we did find interesting is that regardless of their experience, regardless of their Spanish proficiency, all of them spoke about being pushed into the expert role, whether at the very beginning into their training program or right after graduating, which a lot of them spoke feeling uncomfortable with that, being very new in the field and already being perceived as an expert while they're also trying to figure it out. Well, this was not necessarily a major part of our interview. We did ask them about what they found to be useful practices when working with Spanish speaking clients. And these 9 is what we found were the most commonly said. So advocating for themselves, advocating for the population, especially because a lot of them shared that compared to maybe other clients that you might see, most Spanish speaking clients are in survival mode. And so they require different attentions that certain agencies, private practices might not really understand, or those manualized that want to get a client in and out within a couple of weeks don't really understand what's going on there. What they also shared is that their positionality and their identity do matter. A lot of them shared that they could see their clients getting a sense of relief, a sense of connection through them just even showing up being Latinx, as well as flexibility, as kind of what I'm sharing about working in these settings, serving this population. There's just flexibility in what you have to do. Like I mentioned a little bit about the dialects, a lot of cultural humility was brought in about just because I'm from a specific Latin country doesn't mean I truly understand it. I'm having cultural humility in that, as well, although having a starting point. Same thing with the speaking. And then when it came to actual practices, many of them spoke about experiential techniques, so art-based techniques, narrative, things of that nature. And all of them spoke about using psychoeducation pretty consistently, specifically about letting their clients know what the use of counseling is and the point of it, right? And what was interesting is that although a lot of them shared maybe doing individual work or child work, they all added an element of family therapy, which again speaks to the culture. And also right now in counseling, we think about, should it be individual counseling or family counseling? How do you separate those dual relationships? Well, when it came to our specific sample, they really integrated the family into their individual work. And at the same time, a lot of the big practices that we noticed them sharing were intentional self-disclosures, whether it be about their Spanish language use, the country they're from, their immigrational journey, or things of that nature. They all spoke about their self-disclosures. When it comes to training, they all essentially just said, we did not have formal training. Their graduate program did not provide it. As we saw, all these individuals didn't have a Spanish speaker in their training program. And so there was not even like maybe minor meetings, informal meetings between them and that person, because it was not possible. So what they all kind of talked about is becoming self-taught, either just by, going in and providing services and learning, going to work at a specific agency that was advertising that they do Spanish speaking services, or looking for experiences that would increase their proficiency. This either meant going back to a Latin country to practice more of their Spanish, or looking for workshops and things of that nature that might enhance their proficiency. When pressed a little more about what would a training look like, or a certification that would make them feel more competent, a lot of them spoke about there not really being a training or certification that would change things for them that much, in the sense of the support they got, the time that was allowed for them to do certain work, or even a higher pay rate. It wouldn't do any of those things, and therefore, because they already have the skill, they didn't see the need for really looking into those sort of things. So when it comes to supervision, again, there were a myriad of reasons why different individuals sought supervision. But what ended up happening, and you'll see in the second super theme, is that some of our participants did receive and others did not. And so there was a divide between what the seeking really looked like. And so what became the most common theme between all 10 of our participants is really looking for a supervisor who understands the cultural context. More so than the language, they really wanted someone that could really understand the population and the troubles that the population deals with in the United States. We can see in our second subordinate theme, there's a difference between individuals that do receive Spanish supervision and those that do not. Those that received Spanish supervision all spoke about the countertransference and boundaries that issues that they had with working with the population, and how their Spanish-speaking supervisor was able to help them through that. In addition, their site supervisor also encouraged them to do that countertransference work, that boundary work, and even encouraged them in their Spanish language proficiency, regardless of the level. They always encouraged them to do more and encouraged them that they were doing enough, right? Like that their language skill was enough and good enough for them to go work. But they all, again, spoke about that the Spanish-speaking supervisor, while very encouraging, also increased their Spanish competencies, whether it be through clinical vocabulary or dialectical kind of Spanish vocabulary type things, which is an interesting thing that they all spoke about. That what was helpful about these Spanish-speaking supervisors is that they also spoke English, and therefore they could code switch. And they all spoke about essentially a lot of their supervision sessions turning into a mix of Spanish, English, and sometimes Spanglish, depending on what the situation called for, which again led to more relevant supervision. The individuals were able to bring tapes and videos of Spanish-speaking clients and they knew their supervisor would understand. Because their supervisor was or is a bilingual clinician, they're aware of the load. And I'll talk about this a little more in the next couple of slides. A lot of individuals don't really understand the cognitive load that it takes to speak in a different language and then go back to the dominant language, back and forth between Spanish and English speakers, and providing those translation services, also the load of doing those sort of notes, and the extra work that we as Spanish-speaking clinicians do with our clients that might not go unseen by a traditional agency. And this really got brought out by those that did not receive Spanish-speaking supervision. They all mentioned feelings of isolation. They all struggled with countertransference and boundaries for a long time earlier on in their career. They all felt like other people did not understand what it was like to be bilingual. They didn't understand the workload, the positionality, or even what it was like to work with their clients. And what they found was that outside of not feeling seen themselves, a lot of the places that they were working at lacked cultural understanding of the population. And you would see overdiagnosis, misdiagnosis, and things of that nature. And one of the biggest areas of concern for supervision is that what these individuals started doing with their supervisors is it started excluding cases. So although they might really need help with a Spanish-speaking case because their supervisor was not Spanish-speaking, they would exclude those cases because they would never really receive the help that they felt they needed to work in those with those cases. And so later on in the interview, we asked them questions about, okay, well, what would your ideal supervisor look like? And these were the 5 things that they all shared in common. Again, like I shared, they all want someone that understands cultural context, what it's like to work with the population, and what it really means to be Latinx, and things of that nature. They also really want someone that understands the workload of providing bilingual services because there are extra steps that are not talked about. Additionally, they all spoke about needing more resources, whether it be on the clinician side, having a diagnostic tool in Spanish or having a psychoeducational tool in Spanish that they themselves don't have to create, which again leads to more time that we have to spend creating those things, as well as understanding that networks of services that are available to them in their specific state in Spanish. Again, I go back to several clinicians spoke about wanting to refer their clients to specific things and then finding out that they don't have Spanish documents, intakes, or even a Spanish person that could help a person through that. And therefore they have to either go with them or provide the translating services themselves, which again adds more to the clinician's time and plate. They also wanted a supervisor who understands the issues that arise with countertransference and boundaries, because the clinicians that are working with this population, this is a deeply personal population, and things come up that might become deeply personal to the clinician. And again, regardless of language proficiency, they really want an ideal supervisor that empowers them in their use, does not diminish their confidence, meets them where they're at and sees what they can do to grow and also expand their clinical Spanish vocabulary. And so it sounded like, although there were certain people that did receive Spanish-speaking supervision and those that did not, they all shared these 5 things together that we found super interesting, and we'll definitely discuss in a little bit. Like I mentioned earlier, this was not part of the interview. We were not really asking about their where they work outside of some demographical type things, but it came up, and it really came up to a lot of them did their work in community agencies that had advertised, hey, we do work for this population, or we need bilingual counselors, come work for us. And similar to the grouping of receiving and not receiving, we found that there was a big divide between people that talked about their community agency really being supportive and prepared to serve the population and them, and those that were not. Agencies that were prepared had paperwork in Spanish, had a referral network in Spanish. They provided Spanish supervision for their clinicians. And overall, the clinicians did not feel like they were being exploited for having a specific skill, right? It would almost be like if you had a play therapy skill or something that nature, being exploited for that, which we found is happening with people that are not being supported by their agency. So this includes not having paperwork in Spanish, not having that referral system, creating feelings of isolation, being pushed to do translation services, things that might be out of the scope of practice, and even out of the scope of their client. So it might be that somebody else is seeing a Spanish speaking client and now they recognize that the work can't be done and they want to bring the other clinician in to be there as a translator rather than a clinician. So again, blurs the lines. And it really came down to these people feeling exploited, not supported, whether it be with their time, having to do more things than a normal monolingual clinician, not being compensated for the extra work they do, not really receiving any supervision so they can grow and feel better about what's kind of going on, and really not receiving any form of recognition for the extra work that they do. Let's see, I see a question. So any thoughts, perspectives, or experiences within the research on having supervision with bilingual clinicians, but not specifically Spanish or English? There's very few, and outside of Spanish and English, it seems that other languages seem to also want to highlight their experiences. So off the top of my head, I know about Turkish and I know about Korean, and it seems to be similar experiences, but also very struggling with that kind of piece of it, which I'll definitely talk a little bit later of how do you explore specific pieces versus the entire experience, right? Like in our study itself was very much targeted for supervision and very quickly expanded out. And I'll talk about that through our implications. Cool. So a really quick summary of our results. We found similar findings to previous studies, as Kimberly have shared. There was all of them talked about how deeply personal this was, meaningful it was for them, but all mentioned challenges, whether it be in their training, their overall experience, or even seeking or receiving Spanish supervision. What we definitely notice is that just the way people talk about their clinical work is Spanish-speaking supervisors change the trajectory. It seems that Spanish-speaking supervisors are able to provide more confidence and empower our clinicians and put them on a trajectory to not be burnt out either by their work and an agency or something else. What we expected to find by doing this study, we wanted to see if there were any differences in Georgia and North Carolina. While our sample size is a little too small to really make big claims, what we did notice is that Georgia seemed to be more prepared than North Carolina currently, which speaks to how the Spanish-speaking population receives representation. I grew up in Texas and I moved to Georgia because the clients I was working for in Texas kept telling me that they lived in Georgia and that they weren't seen. And when I met Camila and Kimberly, we definitely spoke about that experience, and that's really what influenced our study. And we hope that we can continue highlighting the need for states that are not, quote unquote, the big Spanish-speaking Latinx states to receive the highlight that they deserve because our population's here. We also noticed there's definitely influence on the community agency, right? When it comes to counseling, there's certain settings you can go into, and it seems that settings are noticing the need, but are advertising for more clinicians or for the population without really making the infrastructure. And that is also creating other problems. So we really need to really expand the systems of support for clients, counselors, and supervisors so that people aren't walking into these situations and receiving bad services or just being burnt out. And kind of leading to my next couple of slides, we definitely need more research exploring the specific parts, whether it just be just counseling, just training, just supervision. And an extra piece I wanted to add in there, consultation, because several of them talked about finding other clinicians and things of that nature that they wanted to connect with for more support. Let me see. Cool. I know we have only a couple minutes left, so I'll move a couple through these slides a little bit, but we do think there are implications for counseling, as I've kind of been painting a picture of. Counseling, at least being a clinician, requires several different pieces: training, practicing, supervision, and consultation. Training, I mean, I can't say this enough. We need cultural training. The Latinx population maybe gets a day that gets talked about in a multicultural class, and that's not enough to, speak to that diversity that is Latin America. Also, if we're going to provide a language skill, there should be Spanish trainings, right? What is the clinical words that could be used that would give your message across, which leads more to a standardization of the practice, right? What is the bare minimum that Spanish clinicians should strive for that doesn't currently exist? I would say we need more representation, whether it be as our counselor educators, our supervisors, and clinicians, so we can show that we are here and we can get the trainings that we need. That way we don't end up burnt out. And one of the main findings that we've found in our study is preparing bilingual students to identify structural challenges or organizations or practices that might not be good for them, right? So being there and saying, hey, that agency, while it still advertises working the population, they don't have Spanish speaking supervision. They're not prepared. And so letting our students know how to be able to notice those things. And lastly, really, when it comes to practicing, really creating the support, more information is needed on who is providing and how, expanding our Spanish resources, like I keep saying, whether it be on the clinician end or the resources end of like expanding out referrals. And as I keep saying, understanding the infrastructure that people are creating badly and well, which leads to that supervision piece, right? We definitely need more Spanish supervisors. That became incredibly clear. We need them in academia and we need them on site. And we need to find out, for those that are providing this supervision, what extra barriers existed for them to get to that place. What are they doing to create the foundational work? Many people that said that they had a good experience said, I had a lovely experience because someone did the hard work, did the foundational work for us. And so what is that foundational work and who's doing it? Again, highlighting those agency supervision contexts and highlighting those practices that are being done. What is being done right? What is being done that's harmful? And this is, I'm an immigrant myself, but I find that we don't add that much weight to immigrational context and immigrational trauma and things of that nature. And this is a country full of immigrants, and the fact that we're not talking about that or providing people to with the skills to work through that and any of these facets are highly concerning to me. And last little bit, this was not a major finding, but consultation, they all spoke about creating networks of support, whether in Georgia, North Carolina, and really being jealous or some sort of thing about, hey, they talk about this in California and they talk about this in Texas, maybe Florida. What about us that are here in North Carolina, Georgia, or other states that might not be quote unquote Latinx, Hispanic states, but the population is there. What's being done to support them?
Dan,
Cool.
sorry, I think we're getting down to the time.
We're kind of
yeah,
done.
no,
Yeah,
I appreciate you. You really did an excellent job walking the audience through our results, and I wish we had more time for discussion, but I did add all of our emails in the chat. Please do reach out if there are any questions that we couldn't get to today. If there are any thoughts and things on our research that anyone would like to discuss, our inbox is open for you all. So thank you all.